as kind of just an observation type thing, and yeah, I'll go on this side, so I'm gonna hop down here. No, you stay there. You stay there because the light's good. I wanna make sure the elbow kind of looks the best for you guys. And we can really zoom in, like if you kind of get the screen right like that, maybe from the forearm down, Duke. Awesome. Okay, so this is Josh's elbow, and if you're looking for swelling in the elbow, it's just like the knee. Like imagine the olecranon's like the kneecap. You've got little dimples on both sides. So if you want to see if the swelling's intra-articular, you want to look at that dimple. If you lose that, it gets full, that means you got an intra-articular effusion. Then you start thinking about the fractures, right? The radial head fractures and stuff like that. Olecranon bursitis, where's that gonna be? It's gonna be like a golf ball right on the elbow. You sometimes can feel the thickening of that bursa there, but when you hit it or something like that, it just gets swollen, and it takes a while for those things to go away. So very frustrating for a lot of people because they take good care of it, and then they forget, and then they lean on their elbow, and then that flares it up, or they bump it on the coffee table, and then that really drives them crazy. But sometimes, like, you'll see swelling over the epicondyles, like in a partial tear, like the gentleman just brought up, like if you have an acute injury or a really bad case of tendinopathy, you'll see some swelling sometimes. And then what about a chronic type situation? You might see atrophy of the forearm or the wrist extensors if they don't use it so much and they've had symptoms for a long time. So feeling, you might have saw the one kind of picture in the slides that had the triangle. I like to think about the three kind of bony prominences, the olecranon, the medial epicondyle, and the lateral epicondyle. And these should form an isosceles triangle. So if you do work in a urgent care or an ER or something like that, and you think about fractures, at least like palpate these three dots, because like if there's a fracture, usually one of them's off. It's not an isosceles triangle. But for yourselves, and you can kind of grab your own elbow or the person next to you, just feel the epicondyle, because that's going to be by far and away your most common thing, right? Lateral epicondylosis. So you actually feel like he's a muscular guy, but it's like a button, and it's the most prominent spot. If you kind of feel around and really get a good thing with your thumb, roll over it, you're going to find there's one really pointy area, and that's usually where they're very sensitive. Sometimes they can be a little sore over the first inch and a half because it is the muscle tendon junction, but I'd say like most people, it's right on there. Like how many people have pain on their elbow right now? It's common, like around 10% of people. And then for the medial epicondyle, same thing. I kind of hold, I like kind of holding the arm like this with my fingers on this side, and then I'm rolling over the medial epicondyle. And like your patients, even though it hurts, they'll be very impressed. You're like, oh, you got your elbow problem? Oh, does it hurt right here? And they're like, yeah. And it's like, because you know what it is now, right? That's 90% of what's coming into your office. So the ulnar nerve now is right on the inside portion of the elbow. So it's going to be right on this inner side. So if you get behind the medial epicondyle, roll right into the groove, and then you'll feel like right almost up against the olecranon. And it's this ropey thing, and it makes it feel kind of queasy. It's not so fun. But it's probably a good 4 or 5 millimeters. So you should be able to feel it. Like it's that sensitive thing. If you having trouble feeling it right at the level of the epicondyle, move up like half a centimeter, like kind of just above the epicondyle, and you can roll into it. And then if you wanted to keep your fingers there, then you can bend the elbow, and like Josh can move, like you can feel a click when I'm doing it, and that's rubbing. So like if you have one of those kind of more mobile ulnar nerves, you can feel it. So if you imagine you're doing something repetitively, that thing's going to flare up. That's where you'd also be doing, like, just because we're in the palpation phase, but if you're going to do a Tinel sign, that's where you do your tapping, right over near that nerve. That's the cubital tunnel. Other things is we're going to kind of go over the move portion. So this is 0 if you're going to document full extension. And then so like he might get like, 2 to 3 degrees of extension here. But some people can have 10 to 15 degrees of extension. Now you know they're hypermobile, right? And then you got to go flexion. So this is 90 degrees. And then this is, if you kind of take this angle, that's probably like 40 degrees. So it's like 0 to 100, or like 2 degrees of extension to 140 degrees of flexion. And nice to compare to the other side if you think there's something really wrong with range of motion. And then we can talk about pronation, supination. It's kind of with the elbow kind of bent to 90 degrees. If he's got his thumb up, this is 0. So then pronation is all the way over, and then supination's kind of with the palm up. I always kind of remember supination like soup. Yeah, exactly, giving soup. So like you should get around 80 to 90 degrees of supination, around 70 to 80 degrees of pronation. But for some people who have had old trauma, they lose some of that. But a lot of times, like, they might not complain a lot of elbow problems, but imagine if you're a mechanic, you can't like bend your arm all the way for screwdrivers and things like that, then they start torquing their shoulder, and that's why they come in with shoulder problems. So just kind of think about that. Again, that's an example of someone with really loose joints. And it's important to kind of get an idea of laxity, and this is kind of a bit of a pearl, because when you get a lot of people with tendon problems, they come in with patellofemoral pain, rotator cuff problems, tennis elbow, a lot of times they're very mobile. And you can stretch, and that works, but it's a lot of times they're too mobile on these tendons, so they need to strengthen quite a bit and stabilize their joints. And kind of not do things in the extreme emotion. So like to check flexibility, and you can check this on yourself, you can sometimes see if your thumb goes back. Now Josh is a big muscular guy, but he's not that flexible. Like a lot of people can at least get to 9, like parallel to the forearm. And then if you're very flexible, and I'm fairly flexible, I'm getting stiffer as I get older, you should be able to bring, if you're super flexible, you can touch your thumb to your forearm. But then you're kind of hypermobile. You get a job at Cirque du Soleil. Okay, so this is probably the money slide for the elbow. There's 3 things that are pretty characteristics of tendinopathies, and you can kind of, if you know the anatomy, extend this to any other tendon that you can think of and figure out the exam, because we're talking about tennis elbow and golfer's elbow. These are the big 3. It's tenderness where the tendon's damaged, or the muscle, but tendon. And that's going to be, in this case, the epicondyles. So it's going to be right on that button, right? For the medial, right in there. And then, because it's a wrist extensor, pain with resisted contraction. So like he's going to bring his wrist back, and I'm going to resist it. And so you can try it on yourself. Like, it can't be with the elbow bent. Why is that bad? If I do it like this, is this good? Bend your wrist up. Is that a good test? It's not ideal. It's not bad, but like it's better if you do it extended, because now the muscle tendon unit is at length. You're probably going to elicit more pain that way. And then passive stretching's the other way you do that. Okay? And then you kind of bend it down like we were talking about, getting that stretch. Sometimes you got to rotate the wrist a little bit, but you want to get that nice stretch. And at least 2 to the 3 should be problematic with someone with significant tennis elbow or on that thing. Because like that's how you sometimes tell, like if they're complaining so much, you kind of palpate, but maybe they're more vague and they don't have any pain with resisted. Either they're a really mild case, or you got to start thinking the radial head. Do they have some arthritis in there? Maybe that's not consistent with the diagnosis. So how about medial epicondylosis? Tell me how I examine that based on these 3 things. What do I got to do? Palpate over the medial epicondyle. Cool. So what's the muscle that does the medial epicondyle? It pronates. So pronator teres is the big one. The wrist flexors do insert there, and they can get affected, but pronator teres is more important. So how do I do resisted? I can hold his hand like that, like I'm shaking hands with them, and ask him to turn his hand over, and I try to keep him there. He's a big guy, so he's stronger than I am. But that's where you can, I gotta work out more. But this is where you can really kind of test them, and as long as you provide resistance, if they're painful, they're gonna report something. And then stretching's a little bit harder on this one. This is where you would do the wrist, like the gentle wrist extension. But think about those three things. Think about it when you Achilles, rotator cuff, all that kind of stuff. Those principles stay, and you can kind of tell if it's a tendon problem versus other stuff. There's the epicondyles we talked about. Now let's talk about some of the special tests. And so if you have pain, if you think about all the stuff we've been talking to you about, we're often reproducing the mechanism of injury and provoking the pain. And that's just the way we got to do it. If you want to do a good physical exam, you got to elicit the pain that you're looking for to make the diagnosis. So it's not being mean, it's just doing what you got to do. It's just like if you'd had checking for appendicitis in someone who's vaguely tender, you got to push pretty deep to make sure there's no right lower quadrant. It's okay. You won't hurt somebody just with these exam maneuvers. If they're unstable, then we're going to do our stress tests, very much like the mechanism. So if it's almost like a throwing motion, I'm going to show you how you check for that. And then dysfunction. Sometimes I just like watching how they do it. Like if they can't even take their shirt off and stuff like that, it's pretty bad, tennis elbow or whatever is bothering them. And then the numbness stuff, the nerve stuff, we're going to talk about those. All right, so ulnar collateral ligament stuff. If Josh was going to throw, you can stay sitting like that, Josh, kind of rotated back. Like if he was throwing or doing a pitch like sidearm at 20 to 120 degrees, which is the most vulnerable area, he'd be looking like this. So you can do a valgus stress test just like you do for the knee, and you can fix the wrist and then just push. Hey, Duke, you think you can get me a glass of water? Awesome, awesome. These guys are so nice. This is awesome. Thank you. All right. Okay, so like you hold it distally, push at the joint, and then bend. If you're going to do it in this fashion, you don't want the elbow to bend. If the elbow is flexing, you're probably not applying the pressure on the right thing. You got to go right across the joint, fix it, and then push down. And then you can check side to side. You're just looking for a little give on somebody. If someone's really mobile, they might actually feel a little bit loose, but just make sure it's ligament and not the elbow flexing. I think the easier thing that you can do is this thing called the milking maneuver. And it almost reproduces what you do when you're throwing. You just hold the elbow like this, and just imagine like his thumb's like an udder, and then I'm just pulling down on it. So I'm pulling across the joint. It's a little easier to put pressure on it. But you don't have to explain it's the milking maneuver, but that might sound a little weird. But anyways, this, you're just putting pressure right across that. So that's how you do that. And then there's a more fancy one where you're doing a valgus stress test. You're putting it, and then you're ranging the elbow. Remember, it's 20 to 120 degrees, so they might get to a certain spot where it feels loose. If you want to get fancy, you can do that one as well, just variations. Now, what about the ulnar nerve? So the ulnar nerve, it's right underneath the medial epicondyle, so you want to feel for that. You can tap on it, the Tinel's sign. But the elbow flexion test is probably the best one. I'm going to kind of go forward on that. The elbow flexion test, we talked about how you can get traction injury to the nerve. So just like when you do carpal tunnel tests, the best way to stretch the ulnar nerve is called elbow flexion. So you're going to put your elbows together like that and then have him extend his wrists and hold that for a minute. So you can kind of do your charting and stuff like that while they're doing this. It's really, but get them to hold it because you got to get a little bit of time to get that traction. So if you have, actually this bugs you, then you might have some carpal tunnel or cubital tunnel stuff. And then like we talked about for the ulnar nerve, you can hold here and you can also kind of do that ranging thing to see if they sublux. Those are the kind of the helpful things to figure out if it's ulnar neuropathy. Another thing, if they're kind of weak, they're going to be weak on their intrinsics, right? So you can kind of do the, like have a piece of paper and try to pull it from them. And don't forget about the interossei, like the abductors and the adductors. You can kind of also put a piece of paper in between their fingers and pull that out for their interossei. And then finally, like if they're really bad, you know, their lumbricals will be a problem. Remember, like when the muscles that kind of flex your fingers but keep them extended, those are the ulnar nerve. So those are the tests that you can do there. As Dr. O'Neill very nicely kind of went over yesterday, always think about the neck. When you're thinking about ulnar neuropathies and stuff like that, there can actually be these things called double crush syndromes where they actually get neck problems where the nerve root gets pinched there and then they get pinched again at the elbow. So like you gotta always kind of pay attention to where the nerve's getting kinked. But referred pain down into around the elbow area, C6, C7. Every time I ever hear, hey, I got shoulder pain and it's right up between the shoulder blades, I always think about neck problems. People often forget about that. And then I'll wrap up by talking about thoracic outlet syndrome because we're talking about numbness problems around the arm. And it was alluded to a couple times yesterday, but think about it. We talked about how people get a lot of tendinopathies if they're hypermobile. They might have kind of rolled forward shoulder posture, as we talked about for the shoulder issues. But that, you know, thoracic outlet patients, they're often fairly mobile, and then they're kind of working at a desk or something like that, and that kind of caused a lot of the problems. So thoracic outlet is, again, the kinking of the vessels underneath the distal clavicle. And a lot of people thought there was a big neurogenic thoracic outlet syndrome. People are leaning away that it's not the nerves as much as the vascular stuff, but you know, you'll still read about both. And very important that you see the scalene muscles at the top and the pec minor. Like when people are rolled forward shoulder posture, they're very tight in the pec minor. And that's kind of a big area that they got to stretch out. So the way you can kind of check, the classic is Adson's test, where you hold the radial pulse, you kind of abduct the arm and extend behind, and then you turn the head toward, and then you take a deep breath in, and you have him hold it. And then if that's kind of, his lung kind of pushes up, you might get lost of the radial pulse. Now sometimes it gets light anyways. That can be normal in a lot of normal people. But if you do that, they're kind of getting symptoms and you're losing the pulse, then you can start thinking about thoracic outlet. Another one is Wright's hyperabduction. You just bring it up in the overhead position, because if you imagine some of the people who get this problem, they kind of go to sleep and they like putting their arm up, then their arm goes numb. So that's kind of the story that you'll often get. So you just do that, same kind of thing, you feel it, and you take a deep breath. But the last one, this is my more practical one, because it doesn't involve all this remembering to turn your head and breathe and all this kind of stuff, and it's fairly sensitive. This is called the Ruse test. You just get them to bring their arms back, but as far back as they can, and open and close their hands as fast and hard as you can for 1 minute. So everybody do this. I want to video you. You're going to be on YouTube tonight. And then sometimes you look at their hand and their hand's kind of numb already. You know there's some vascular issues. But if they start to fatigue, they start going like, yeah, it's harder on this side, or they actually start getting the numbness, now you know they got a thoracic outlet component, which is but you got to do it for a minute. Got to do it for a minute. How about everyone who has symptoms keep their hands up after this? Or maybe put it down, I guess. if it's hurting. But I bet you some of you in the audience start going like, yeah, it's really hard to keep that up, or one side's getting more tired than the other side. Those are kind of the things that thoracic outlet syndrome will do. Thanks. So, you know, with that, I want to keep things rolling so that we're on time, but I think we got a couple of minutes for some questions. That's kind of the exam. Like, last thing, vascular problems. In some athletes, you can get a DVT in the shoulder or proximal arm, and just look for that. The whole arm will be subtly swollen. So if you see that, send them for the ultrasound to rule out a DVT. All right.